Okay, so I'll continue. So complications that occur during the emergent phase are the organ damaged, and three areas are most compromised. It's cardiovascular, respiratory, and urinary. So cardiovascular is our low blood pressure, low perfusion to the organs, and leakage. Respiratory, we have carbon monoxide poisoning and airway obstruction. Airway obstruction, and we have pulmonary edema slash effusion. So urinary is acute tubular necrosis, kidney injury from the myoglobin and hemoglobin flowing in the urine, and of course our due to decreased blood pressure. So dysrhythmias. Hypovolemic shock can occur. Oh boy, yeah. Cardiovascular. I forgot to include dysrhythmias. Yes. And we got hypovolemic shock. So circulation impairment from circumferential burns. True too. So swelling. Swelling goes here too. Circulation impairment from circumferential burns. That's what they perform the escharotomy for, or fasciotomy at times. Sludging, clots too. Won't go in here. So sludging, increased viscosity, decreased microcirculation may cause damage to the skin structures. Adequate fluid resuscitation would be beneficial. So respiratory system, upon admission, they have to have a fiber optic bronchoscopy done. They go there with the camera and take a peek. And carboxyhemoglobin levels are being checked to confirm lung injury. No, correction. Carboxyhemoglobin levels are checked to see if they have carbon monoxide poisoning. And if that is high, probably lung injury will happen too from inhalation of hot air. And fiber optic would confirm the lung injury. Sputum is taken for carbon, and they can come in and have a chest x-ray and ABG drawn, and they will come back normal. But then during the 24 hours, they can become abnormal. So that is not the definitive, not to test, that will not rule it out. They're more like for monitoring. So patient with chronic conditions and burns. So COPD and heart failure, fluid restrictions. Fluid restrictions, it cannot be vigorous. Resuscitation too vigorous. Yes, it cannot be too vigorous. Complication of hemodynamic complications need hemodynamic monitoring. So they'll insert the hemodynamic monitoring device and monitor the blood pressure and output. They want to keep it above 90, I think. They want to keep it blood pressure above 90 and systolic, and then heart rate would they want to keep it now more than 120, so more sensitive. And we got to monitor their urine output, and that would be 0.5 milliliters minimum per kilogram per hour. So respiratory problems, increased likelihood of respiratory infections with pneumonia. Venous thromboembolism can be treated with enoxaparin, Lovenox. Urinary system. Acute tubular necrosis can occur from decreased blood supply, renal ischemia, acute kidney injury. Myoglobin hemoglobin can cause occlusion of the renal tubules. So nursing care, what the nurse is going to do. So the nurse will manage the airways, fluid therapy, monitor those input-output, the rate, and wound care, washing the wounds and applying the creams like silver sulfadiazine, and others. Also grafts, monitor that the grafts are in place. And yeah, positioning and splinting. So airway management, so either it's going to be endotracheal, or orotracheal intubation, burn to the face, intubation within 2 hours, ventilatory support based on the ABG. So they check the ABG and then they adjust the setting in this ventilator. Extubation after 6 days when edema resolves. Yeah, escharotomy to the chest wall to relieve respiratory distress. So they will take this fella and they will cut off. Gosh. I'll take this fella and they will cut along the sides and perform the escharotomy. Within the 12 hours, perform fiber optic bronchoscopy. So upon admission, fiber optic bronchoscopy should be done, and 100% humidified O2 for carbon monoxide or hydrogen cyanide until carboxyhemoglobin levels return to normal. So I have this little drawing here, and the suctioning would be performed every 2 hours, as well as repositioning, probably keeping their hands above to decrease the fluid. But anyway, they should be in high Fowler's position unless spinal injury, that neck injury or spinal injury from the electric shock. Electric shock can break those parts. Deep breathing and coughing if they are awake. So ABGs, upon what the ABGs are, the ventilator settings will be adjusted, and they might consider to keep PEEP at the PEEP so the alveoli stay open. So fluid therapy, they would come in, they would get 2 large bore needles, 16 gauge, and then or central line if their total body surface area was burnt more than 30%. They will start the resuscitation with lactated ringers. To be honest, in emergency, in the ambulance, they will use just fluids, just normal saline, 0.9%. And later on, already in the hospital, they're getting lactated rings. Lactated rings has normal sodium chloride, potassium chloride, calcium chloride with water, sodium, this stuff, electrolyte, and the pH is 6.5. So afterwards, after 12 hours, when capillary permeability returns to normal, they can get that albumin that left their blood vessels, about albumin 5%. Mannitol with electrical injury. Why they're getting that? It's, if anyone wants to answer, that would be nice. Use urine output as parameter to assess effectiveness of fluid therapy. So 0.5 to 1 milliliter is the goal, or 100 milliliter for electric burn with hemoglobin urea and myoglobin urea. Okay. No. Alright. Cardiac parameters. So here, mean arterial pressure should be above 65 millimeters mercury. Systolic blood pressure above 90. Heart rate above 100. Oh, it's above 100 beats per minute. Wound care. Clean and debride. So nurse would clean and debride with scissors and forceps to remove necrotic skin. Escharotomies or fasciotomies performed by the physicians. 1 daily shower, morning and evening dressing changes. So our antibacterial creams will go here, and new antibacterial dressing changes every 3 to 14 days, depending on the agent that is being used. So burnt wound treatment can be open or closed. Permanent skin coverage is the primary goal for wound care. So with open wound treatment, it's mostly for the face. Burn is covered with antimicrobial dressing and left open. And then with extremities, it would be the closed. Multiple dressing changes. Sterile gauzes are impregnated with topical antimicrobial, changed every 24 hours to 14 days. And most of the hospitals and centers, they support concept of moist wound healing and the use of dressings, cover to burn area, with the exception of facial burns. So the reason they want to use the moist wound healing method is to allow those little cells to travel, so they have some pathways they can take to travel farther. And by the way, they said that it was said that after a burn from the wound edges, where's my pen? Synchronizing. So after they can travel up to 1 centimeter, the cells from the edges of the burn can travel, that keratinocytes or fibroblasts, they can travel 1 centimeter from the edges and heal, re-epithelialize the tissue. So during the wound care, it's important to wear personal protective equipment: the hat, the gowns, the gloves, the mask, and the shoes to keep the room warm. Also important for their hypothermia. We don't want them to get any infections, and we don't want them to get cold. And no internal systemic antibiotics are used unless they have sepsis. So all the antibiotics that they're getting is the creams. The reason they're getting creams and no systemic, because they don't have any vascular supply to the tissues in order to deliver the antibiotic. Additional management: extend and elevate arm to monitor edema, remove spleen frequently, inspect area for pressure. Okay. Additional management: extend and elevate arms to minimize edema, so they will be sitting like this, or maybe even like this. The legs are burnt. And and that would minimize the edema. And we want to keep their hands relatively straight, so it would stretch and prevent contractions. Or move, if they're able to. Move them through the pain. Remove splints frequently and inspect areas for pressure. So you would check the areas for pressure. Alright, drug therapy. Well, there's quite a few drugs, and then the intestinal. So they should get the analgesics, the sedatives, IV. IV route is the best. If they get an IM, they can get an IM because first of all, it's not going to be delivered on time, and then when the fluid mobilizes, they will get overdosed on the medicine that was in the tissues, in the muscle. GI oral not going to work too because the GI function is slow. They have the paralytic ileus. Analgesics that we're going to use are morphine, Ivinza, sustained release morphine, MC-Contin, hydromorphine dilaudid, sustained release hydromorphine dilaudid, CR, fentanyl, sublimase, oxycodone acetaminophen Percocet, methadone, dolophine, ketorolac, that's our non-steroidal anti-inflammatory, and then gabapentin, Neurontin. Sedatives, lorazepam, Ativan, midazolam, Versed. It provided short amnesiac effect. It's very important to check what you're giving. Midazolam, Versed, and not some kind of other drug. Velpidem, Ambien. Antidepressants, sertraline, Zoloft, citalopram, Celexa, decrease the depression. Anticoagulants, enoxaparin, Lovenox, heparin. So nutritional support, vitamin A, C, E, and multivitamins promote wound healing. Minerals, zinc, iron, promote cell integrity, hemoglobin formation. Oxandrolone, oxandrin, promote weight gain. Okay, gastrointestinal support, we get that the patient might get that curling ulcer from decreased stomach supply of blood and from the decreased stomach acid and risk of curling ulcer. So decreased blood supply by increased stomach acid. Ranitidine, Zentac can be given, and esomeprazole. All those H receptor or proton pump inhibitor and H histamine something receptor blocker. Calcium carbonate and magnesium. Magnesium carbonate, Mylanta, aluminum hydroxide, and magnesium hydroxide can be given to neutralize stomach acid. Nystatin, mycostatin, promote growth of the candida. Promote overgrowth of candida.